So, welcome to everyone who's joined us today for our final session of our annual forum at Cavernoma Alliance UK. And we're thrilled to have had so many people with us throughout the day. So, to introduce Dr. Greg James. Dr. Greg James is a consultant paediatric neurosurgeon at Great Ormond Street Hospital. I think some of you on the webinar today will know him. He has a major clinical and research interest in neurovascular disease in children, including Cavernoma. Greg is the lead for the Children's Gamma Knife Centre at GOSH and UCLH and the Fellowship Programme Director at GOSH. And Greg will be speaking to us today on paediatric neurology.
Okay, well, thank you everyone for being here. I know it's a beautiful sunny day and lots of other things to do, and I guess some people will watch this on catch up. And thank you very much for Helen for inviting me. I think the Cavernoma Alliance is an amazing charity, and I'm always very honoured when they reach out for me to talk. I gave a talk a couple of years ago before the pandemic when we were still doing a lot of things face to face, and some of you will have maybe been there. A few of the slides at the beginning are the same, but then it's quite different. So hopefully it won't be too boring, and I'll try and keep it relatively to the point. I'm a neurosurgeon by trade, so I saw the schedule for the talk today, and I know you had some science and some neurology, so I thought I'd focus mainly on the surgical aspects and the questions I get asked by families as a neurosurgeon about, mainly the operative aspects of Cavernoma. So that's really what I'm focusing on. But if there are questions that people have about other aspects, please put them in the chat, and I'm happy to try and talk about those at the end. So who am I? Well, I'm a neurosurgeon at Great Ormond Street. Great Ormond Street is a children's hospital in London. We've got the largest paediatric neurosurgery unit in the UK. We take around a lot of surgeons, a lot of operations every year. We have a big team of surgeons. We all subspecialize, and myself and my colleague, Mr. Silver, are the two surgeons that specialize in neurovascular conditions. So that's things like aneurysms, AVMs, and also cavernomas. I'm also an honorary associate professor at University College London, and I'm a part of a lab, Professor Atwell's lab, where we examine the basic science underpinning neurovascular diseases in children. We're not doing any research projects specifically on Cavernoma currently, but hopefully some of it will generalize, because a lot of it's about pediatric stroke, which is clearly very relevant. And I guess most importantly, I see a lot of kids with Cavernoma pretty much every week in my clinic. I see at least one patient with Cavernoma. Many of them I'm following up, and I've got to know families over a long time. Many of those children have not needed surgery or any treatment, but simply under monitoring. Some of them I've operated on, some of them we've done other forms of treatment. So I picked up a bit of experience through that, and I really feel honoured and privileged. I've learned from the families really and from the children. So what I'm reporting back to you is based on that clinical experience that I've gained. There's lots of questions that come up when people meet me in clinic, and I'm speaking to an expert audience because you're all Cavernoma Alliance people, so you'll know the answers to a lot of these, and you'll know also how uncertain the answers to a lot of these things are. It's actually, as you know, it's still actually quite difficult on a scientific perspective to really define a Cavernoma very accurately, and often in clinic, parents will have been seen and often told by a non-specialist, or there's this thing on your scan, we think it's a Cavernoma, and often won't be given very much information, and often spend quite a lot of time explaining a little bit about the background. But I'm not going to do that today, because like I said, most of you guys, whether very factual here, will know those things already. If any of you are interested, you can reach out to me. So I guess I'm going to talk more about the things that are kind of specifically relevant as a neurosurgeon. And I guess the big question clearly with children, often with a Cavernoma presentation, and we'll talk a bit about the types of presentations. Actually, by the time children see me, they're usually very well. There are certain conditions I look after where children have very devastating bleeds in the brain and are very sick, and I'm meeting families in the intensive care unit. Thankfully, although that is, I wouldn't say it never happens with Cavernoma, it's much less likely. And often I'm meeting families in the clinic, and actually the child is very well. They may have had a headache, or they may have had a seizure, but then by the time they've come to see me, they're fully recovered, back at school. And so the worry isn't so much about what's happened, but what will happen in the future. And I guess that's really what, the other talks you've heard today are all about. Rustam study, the CARE trial, the basic science is all about trying to predict which Cavernomas cause trouble and which ones potentially are harmful. And I guess that's the kind of $1 million question in Cavernoma. But these are the kind of questions what I grow get more. Often people are very interested. People are often disappointed when I don't talk about size, because I think it's a very natural thing to say, well, I've got an 8mm Cavernoma, is that worse than a 5mm Cavernoma? Actually, those of us who are in the trade, the size often isn't that relevant unless they're very, very, very big. because it's more the way they behave. Are they active? Are they bleeding? Rather than how big they are. And of course, their location, if the cabanoma is in a very critical location, like the brainstem or the speech area, is much more likely to cause trouble than one in a less important area of the brain. And that's always an interesting question. People will point in the cabanoma and say, well, what does that do? What bit of the brain is that? What does that do? And again, I often disappoint them by starting to wax lyrical about it. It's a bit more complicated than that. The brain isn't a simple computer, but there are certainly some areas where cavanomas can cause more trouble than others. And of course, I guess these are the questions as a surgeon that are really relevant to me, which is, should I have an operation? Should I have another form of treatment? Should I have gamma knife, which is something I also do? Should I have medication? I've read about things on the internet and, questions like this. And then ultimately, my job is to try and guide people to help make a decision with them. Are children just small? Adults? When it comes to cavanoma, maybe. I think there are kind of classic presentations in children which are different from adults clinically, and I think it's one of the reasons why, mea culpa, I've not been very good at recruiting to the care trial, partly because I usually have a clear idea what I think the recommendation is. I'm not often an equipoise, as you know. The care trial is about not knowing what to do, and generally I have quite a strong opinion about what to do, because most children will fit into a category where treatment is usually relatively clear in terms of what's needed. And I think that's probably a bit different from adults. I think in adults, cavanoma is much more likely to present in a more kind of sporadic way, or often you might have a bleed and go some time and have, whereas with children, often they can present with a very big bleed initially or present incidentally, and it's rare for them to move between those different groups. I'll talk a little bit about that. I mean, ultimately, the problem with any neurovascular condition, and this is true with all the things I look after, aneurysms, AVMs, and cavanomas, is Moyamoya disease, all these conditions that I look after, that it all boils down to uncertainty. My colleagues who look after children with brain tumours, there is no uncertainty. If you don't treat it, the brain tumour will grow and the child will not survive. Where cavanomas aren't like that. There's a chance you may have a cavanoma and it may never cause you trouble. Or it may not cause you for trouble for many years and then cause trouble at a date in the future. So part of what we have to manage is that uncertainty, and studies like the CARE trial or other studies can try and help answer those questions on a population level and say, well, this percentage of cavanomas may cause trouble. But for the individual child, it's always going to be impossible, however clever we get with scans and trials and to predict the future, because we can't predict the future for anything, in life. So part of learning to live with one of these conditions is to try and learn to live with that uncertainty. And one of the things that it's, when I was trained as a neurosurgeon, I was trained in how to do operations, I was trained in how to look after patients with diseases, and I was pretty well trained in all that stuff. But actually taking families through that uncertainty is something that I've had to learn to do over the years myself, because it's not something I think that's well trained in. Probably some of you had that experience with doctors where it can be difficult to get us to give an opinion on because the uncertainty, it can be difficult to manage, and that does lead to a lot of anxiety in and of itself above the actual disease. We know that many cavanomas won't cause problems. Predicting their behaviour is difficult, and obviously in children it's even more difficult because they're going to be around for a lot longer. Kids born nowadays are going to live into their late 80s, 90s. So, you're not just predicting what's going to happen in the next couple of years. And that's important for our treatments too. If we do a treatment in a child that causes a permanent problem, an operation that causes a complication, the long-term effects of that are going to be much more significant than in an elderly adult. So we have to, the information that we have in adults is even more difficult to interpret in children, because the longer your lifespan, the more difficult to predict. These are my friends. You might sort of see here, this is me and my friend Ed. Actually, Ed is here. And Mike Scott, who's sadly quite ill now, who are two neurovascular surgeons from Boston Children's Hospital, who are colleagues and friends of mine. And they've studied cavanoma quite a lot. And this is quite a good paper looking at the natural history of cavanoma in children. This is Mike Scott and Ed Smith. Darren Orbach's their radiologist. They looked at 167 kids with cavanoma, so it's the biggest sort of study that I'm aware of anyway. And most kids were around 10, boys and girls about equal. And these are the kind of classic presentations we're going to talk about. So One of the problems is, as surgeons, the ones we tend to see tend to be the ones that present with bleeds. There will be more incidental ones out there that we're not so aware of, because they often don't necessarily get referred to surgeons. And, you know, quite a high proportion of multiple. So I think that's another difference between children and adults, is you will see more familial and multiple cases in kids. Overall rate. So people often ask that, what's the chances of bleeding per year? And the problem is those rates are often compiled from a large number of studies, but they reflect the kind of background rate that often is quoted in adult studies, around 2 to 4%, much lower if incidental. So this is a really important thing. If you present with a bleed, your bleeding risk is probably in this ballpark. If you're presenting with incidental findings, so you've had an MRI scan for something completely different, as we know lots of kids do now, head injury, headaches, and found to have a cabanoma, it hasn't bled, the risk of further bleeding is low. It's less than 1% per year. Yeah. And there is this phenomenon of clustering. So if you have a bleed, you're much more likely to bleed again within that first few years after the bleed. So they kind of become active. And in my mind, that's how I think of cavanomas, as an active thing, but then become less active. Their risk factors were presenting with a bleed, brainstem location, which is well described, and an associated DVA, which is an abnormal vein associated with it. But interestingly, age wasn't a risk factor. Multiple CCA, multiple cavanomas or familial causes weren't related. So it's pretty, in my mind, pretty obvious, at least the first two, that those are going to be more likely to bleed again. If you've had a bleed before, that's probably the biggest predictor of whether you're going to bleed again. So should we operate on all those patients with risk factors? Well, and I think this comes to really what I'm mainly going to talk about, which is decision making. I mean, I think the operator, so again, like I said, I think I'm a reasonably competent surgeon. I'm reasonably well trained, but actually the difficult bit is before you get into the operating room, it's the making the decision about which patient to get an operation. Ultimately, there isn't necessarily a right or wrong answer. I mean, occasionally there are situations where are very, very clear, and I'll show you some examples where things are very clear that you should or shouldn't operate. But often there are pros and cons, and ultimately it's always going to be you as the family, or it's going to make the ultimate decision. It has to be. That's the concept of informed consent. But it's a team-based approach, and there will be different teams: the neurovascular team, the epilepsy team, pediatric neurology team involved, and ultimately you have to make a team of all the teams with the family, and that gives you the team that needs to work through. And the important thing, I think, with cabanoma, it's very rare for this to be something that has to be done quickly. You've got time to think about things, you've got time to speak to different people, different doctors, get second opinions, which I think is a healthy thing to do. And it's rare that you're going to have to make a decision right here and now. Occasionally, I've had, in my 10 years as a consultant, I can think of maybe 2 or 3 patients probably I've operated sort of semi-emergently for cabanoma. But most of them, you have opportunity to think about things. And even in those patients, we're usually not going straight to theatre. We've got a few days to talk about things and make a decision. So there are sort of 3 classic presentations, I think, in kids. And I think that's a little bit different from adults, where bleeding can be a little bit more varied in terms of where the cabanoma is. But the 3 presentations that I see regularly, and I guess the other thing to say is definitely familial cabanoma is probably more common in children and in adults. So your sort of 3 classic presentations. One is your big bleed, basically. So these are kids where they have become very symptomatic very quickly, often well beforehand with no necessary medical history. This was a boy around 10 years old who basically was found drowsy, confused, big bleed in the thalamus, a lot of mass effects, some blood in the ventricles, so quite unwell. And this is one of the 3 kind of kids I was talking about as an emergent. So we watched him for a little bit, but he was getting a bit worse. And in these cases, you need to probably take the cabanoma out to relieve the mass effects and to prevent bleeding from happening in future. So he had surgery. That's the post-op scan with me as a neurovascular surgeon, and he's done well from that. As you can probably see, if you're very eagle-eyed, he has got other cavanomas. This was actually the presentation of multiple cavanomas, so he remains under follow-up for the cavanomas, but he's not required any other surgery. The other classic thing we see in the pediatric age group is intractable seizures. So what intractable means is seizures that don't respond to medication. So most epilepsy is quite a common condition in kids. Lots of kids have fits, and many of those are managed very easily on medication. But there's a small proportion of kids who will continue to have seizures, and some of those will have cabanoma. And this is a girl who had, again, you can see multiple cavanomas, but this was but very difficult to manage seizures. And really there, as a neurovascular surgeon, I will say, actually, you don't need to see me. You want to see the epilepsy team, the children's epilepsy team, because the workup and treatment and surgery in this case is slightly different. And I'll talk a bit about that in a minute. So, that's another kind of classic presentation, and their decision making is very much guided by the epilepsy team in terms of what they think the best management for the seizures are and whether the surgery could play a role in that. So instead of the surgery being like in the first case, which is more about preventing bleeding and reducing pressure in the brain, this is more about preventing seizures in the long term. And the final presentation, which I see probably most, is incidental. This is a kid who fell over and banged his head. And they did a CT scan and an MRI scan and found this, cabanoma, which looked pretty quiescent. It's in quite what we call an eloquent area, so an area of the brain that we don't particularly want to operate on unless we have to, because it's near the visual tracts. So, in this patient, we tend to leave things alone. We tend to say, don't operate. Your child is asymptomatic, they're fine. They wouldn't have known about this unless you did a CT or MRI scan, but we need to follow up, and we would keep an eye on things, but we wouldn't recommend surgery at this stage. And that's one of the reasons I think why, like I said, mea culpa, I wasn't very good in recruiting at the cabinet. I screened a lot of patients for care, but I tended to recommend those treatments based on the presentation. That you do get a few patients who present in other ways, but most of them, I think, present with those kind of classic presentations. So if you present with a bleed, so if you present with bleeding, and particularly multiple bleeding, you probably need to be under someone like me, a pediatric neurovascular surgeon, and my team. If you've got ongoing difficult to manage seizures, you probably need to be under the Children's Epilepsy Service. And there are 4 of those centres in the UK: one at Great Ormond Street with Kings, one in Bristol, one in Birmingham, and one between Liverpool and Manchester. And if you've got a completely incidental cabanoma, you may not need to see a neurosurgeon at all. A lot of that could be managed by a neurologist or a general paediatrician, although many of them will refer to me just for a surgical opinion. And often I end up following these families up just because I've got quite a lot of experience with cabanoma, so families often quite like having that opportunity to access that knowledge, whereas a general paediatrics may not have as much experience because obviously they deal with a much more wider range of conditions. Why is epilepsy surgery different? So this is a question I sometimes get asked, because sometimes families will find me because they know I have an interest in cabanoma, and they'll come and see me and they'll say, but the child is having very bad seizures. And I'll say, well, actually, I don't think I'm the right person. I think you should see the epilepsy team. And they'll say, well, why? It's all the same. It's a cabanoma, right? Well, no, not really, because the way epilepsy works in the brain is that if you have long-standing, the cabanoma may be the original cause of seizures, but it may not. Yeah. So what the epilepsy surgery team do is try and work out what the cause of the epilepsy is. Number one, it may not be the cabanoma. The other thing is it may be the cabanoma, but what can happen if you have epilepsy, particularly in children, if you have a long-standing epilepsy, is other parts of the brain can become involved. So actually just taking out the cabanoma, which is a kind of operation I do, may not be the right operation. You may need to actually have some of the brain, the non-cabanoma brain operated on as well, because just removing the cabanoma alone often doesn't treat seizures very successfully in long-term seizures. So in those patients, I will refer them to my colleagues, Martin Tisdall and Zubair here from the epilepsy team. And it may involve a lot more workup in terms of trying to understand where the epilepsy comes from. And like I said, I think in that situation, that's really the correct team to be under, because for stopping bleeding, removing the cabanoma in the way that I do it is sufficient. But if you're trying to stop long-term intractable seizures, then the operation may be different. It may not even involve the cabanoma at all. So I'm going to show you a video. So I don't know if anyone's squeamish at all. I mean, it's not particularly horrible, I don't think. I mean, but obviously I'm a surgeon, so I'm used to seeing these things. But I thought I'd show a video just so people can understand a little bit about how, just an example case really of a patient we operated and how we do the surgery, because often people are quite interested in that aspect. So this video, this is an operation I did with my colleague, Mr. Silver. We often operate these big cavanomas together. It's quite good to work as 2 consultants because you get a little bit more, it's really about talking through things and making decisions. This is a little 4-year-old boy who presented quite symptomatic. And like I said, this is your kind of classic big bleed presentation. So big left, so dominant area. So because it's dominant, I'm just going to go back to that picture quickly. So number one, we have to shave a bit of hair. It does grow back. These are electrodes. So because this cabanoma was near some important areas of the brain, the motor area and the sensory area, we did some what's called monitoring. So we used some electrical monitoring during the operation to keep an eye on the function of all those things to make sure we don't cause any injury. This is what happens when we open the bone. People often ask about that. We use a special drill. We take the bone off, we put it back at the end, we fix it in place. So often this is what you'll see when you open up with a cabanoma. You'll see normal brain, and then you'll see a little bit of staining. So normal brain looks kind of whitish. And then we do something called mapping. So we're checking which parts of the brain do what by using little electrodes. And here is our cabanoma. It's under a little spidery layer called arachnoid. So we're going to open that up. This is all under the microscope. This is a tiny little hypodermic needle. I often use this because they're very nice and sharp, because they're always new. So we're opening that lining of the brain called the arachnoid, and now you can start to see the cabanoma underneath. A little bit of bleeding as we open up, but we get on top of that quite quickly. Cavanomas themselves, compared to some vascular lesions, don't bleed very much from surgery usually, but they can do. There's a little bit of blood. So this is some of the old blood that's around the cabanoma from the bleeding. In terms of timing, it's often easier to operate relatively soon after the bleed because you've almost got the cabanoma sitting in a little pool of blood, which makes it easier to remove safely because it gives you a bit of protection from the brain. So I often recommend, if you are going to operate acutely, to do it within a few weeks of the bleed, although it's not always necessary to operate at that stage. So here where we're gradually working around, essentially separating the cabanoma. So the cabanoma, it doesn't have big arteries going into it like an AVM, but it has lots of tiny little blood vessels that feed into it. So what we're doing here is we're gradually dividing those off, gradually peeling away the normal brain from the cabanoma, protecting it as much as possible. These little pads, little cotton patties, we use to protect the underlying brain as we're working around. And you literally work around it like a little I don't really know how to describe it, but you work around it, peeling it away. And you can see here you've got a nice normal brain and the cabanoma, and you're gradually peeling it away. And obviously you just need to go very slowly, very painstakingly, so you don't injure the underlying brain. So I'm just going to flip through. I could watch this all day because I love neurosurgery. It probably is less interesting for you guys, but this is just showing the deeper part. The interesting thing here is what we found at the end is we took out this big cav, and often they come out as a big whole lump. But we noticed on the MRI scan, and this is always really important because you think, oh look, cavanoma's gone, but there was a tiny little dot that was a bit deeper in. So we looked for that, and we often use things during the operation. We can use MRI scans, ultrasounds, to find that little tiny dot, and we're able to remove it because it's really important to try and remove all the cabanoma, not leave a residual, because it makes recurrence more likely. So that's surgery. The advantage of surgery clearly is that it can potentially be curative. So if you do an operation, especially on a solitary cabanoma like the one I just showed you, and you remove it completely, which we did. I can show you the scan at the end. Yeah, you can see that it's gone completely. And that was a little bit we thought that we managed to extract. So once it's done, it's gone. It's great from that perspective. So, and as for a family, that can be a big weight off the mind. It's done, it's gone. The downsides, though, are obvious. You've seen already. It's a head shave, general anaesthetic, permanent scar, lengthy operation. This operation probably took about 4 hours in hospital for 4 or 5 nights. And the risks of surgery. And when we talk about surgical risks, we're talking about potentially very serious risks. Injury to the brain, a stroke, a seizure, even life-threatening risks. Thankfully, in my practice, those are very, very rare, but they can happen. And as I mentioned before, sometimes even if you get a clean scan, I've had this patients where at the time of surgery didn't appear to be a residual cabanoma. Initial scan didn't show any residual cabanoma, but there is a risk. I've had 1 or 2 patients where they've had a late recurrence. So, even with successful surgery, there is a risk of recurrence. So, it does have its very attractive side surgery, but it does have some downsides too. Gamma knife, people often ask me about gamma knife. Gamma knife is basically a form of radiation treatment. So it's a slightly silly name. It doesn't involve a knife. It involves using collimation, so focusing of thin beams of radiation onto one spot. In children, we undertake it under general anaesthetic. This is what a gamma knife machine looks like. It looks like a kind of scanner. And this is the way we do gamma knife at Great Ormond Street. We have children we bring with their parents to the National Hospital where Neil Kitchen works, who works with me on this. Many of you will know Neil Kitchen because he's been involved with the Cavernoma Alliance for a long time. He's an adult neurosurgeon who shares my interest in Cavernoma and who trained me actually. So we bring the children to Queen Square. We have a paediatric anaesthesia team. So these are anaesthetists for Great Ormond Street. So it's a very nice and child-friendly environment, very skilled anaesthetists. And then we so in adults, Gamma Knife usually done the local anaesthetic, but in kids we always do it the general anaesthetic. This is me and Cornell, the Gamma Knife fellow. So we attach this special frame, which allows us to localize very accurately with Cavernoma. It says Neil Kitchen, for those of you that know him. And we apply the frame, all painless, child to sleep. We would, for a Cavernoma, need an angiogram. This is a different type of condition this girl had. We do an MRI scan with the frame on. And then we do the planning. The planning's a really important part because with Gamma Knife, the whole reason it's a useful treatment is it can deliver a high dose of radiation to the Cavernoma, but to a low dose of radiation to the surrounding brain. So it's different from sort of traditional radiotherapy. So you may have known family members, you've had sort of radiotherapy, things like breast cancer or bowel cancer involves going to the hospital multiple times, you lose your hair, that kind of stuff. With Gamma Knife, you don't have those problems. It's a one-off treatment, but it's only good for small lesions, really less than 3 centimeters. And the planning stage is really, really important. So there's me back of my head, a little bit less grey there because it's a few years ago. This is our physicist, this is our radiologist, this is Neil Kitchen, another neurosurgeon. We plan a way of delivering the dose of radiation so it conforms to the Cavernoma with a low dose of surrounding tissue. Once the planning is complete, the actual treatment is undertaken. The length of treatment can vary from half an hour up to 2 hours, depending on the complexity of the treatment. We take the frame off, we come back to Great Ormond Street, and the child is woken up. This girl gave permission for photos to be taken. She was very kindly agreed, and this is at the end. And actually nowadays, I used to keep kids overnight. I've now stopped doing that. I now send everyone home the same day. So the advantages of Gamma Knife obviously are that it's very, compared to surgery, it's less invasive. You don't have to stay in the hospital overnight. You're back at school in a day or two. You don't have any hair shave. The risks of complications on the day are very low. Yeah, you have that frame thing on, so you sometimes get a bleeding or oozing from the pin side. You have a reaction to the anesthetic, you have a bit of a headache, but generally the risk of something happening on the day is very low. The downsides are it takes time, so the radiation takes some time to work. The other thing in Cavernoma is it's quite difficult to know if it has worked, because with surgery you can do a scan and say your Cavernoma is gone. With Gamma Knife, it doesn't get rid of the Cavernoma, it just seems to somehow stabilize it and reduce the risk of bleeding. So it can be quite difficult, because if I see you 2 years later and you haven't had a bleed from your Cavernoma, you don't know if that's the Gamma Knife or that's the natural history of the condition, which is difficult as a surgeon. There are quite a few papers now looking at Gamma Knife and Cavernoma, mainly in adults, which have been very suggestive that it is an effective treatment in reducing bleed rates. But I guess it's difficult on an individual patient basis to say that very confidently. There are side effects to Gamma Knife too. The risk of any problems on the day, unlike surgery, is very low, but the radiation can cause swelling or problems down the line, which can cause side effects. It's not a completely risk-free option either. And generally, I think in kids, I'm a little bit, I think Gamma Knife is an option, but probably shouldn't be the first-time option in most kids. What about monitoring? So when I say you have an operation, you have Gamma Knife, well, actually, most of the patients I see, I don't do either. I monitor them. What does that actually mean? And I think that's a really good question. I think the most important monitoring is clinical. And by that's just when doctors say, let's just see how you do. So I try and get a family to take a proactive role. So I'll say, well, I'll see you in a couple of years. But clearly, if your child has symptoms prior to that, then you need to let me know. And one of the good things at Great Ormond Street now, we have quite a good system where people can contact us directly via the it's called a MyGosh app, where they can send in. So you can say, oh, actually, we had some headaches or some other symptoms. Because ultimately, you can do scans and you can do MRI scans, whenever you want. But you won't necessarily see any changes, and there's an argument, if you don't have any symptoms, maybe you shouldn't do any scans at all. In reality, I often do at least one follow-up scan, unless they're very tiny cavernomas, just because I think if you see some changes on the follow-up scan, even if they're clinically silent, as in the kid hasn't had any symptoms, it may suggest that cabanoma is one that could cause trouble in future and needs to be watched a little bit closer. So it's important, though, in kids to realize doing a scan isn't always a straightforward thing. And, in adults, it's very easy as an adult to stick an adult in an MRI scanner every year. Putting a 3-year-old or 4-year-old in an MRI scanner is a different proposition. They have to lie completely still for 40 minutes. Many of them won't do that. So they need to have sedation or anesthesia. So there's risks involved in that. It makes it a bigger deal for the family. You have to starve the patient. You have to come into hospital. You may have to stay overnight. So, it's not quite as easy as saying to an adult, yeah, let's just do a scan. I tend to be quite judicious with my scanning in cabanoma for that reason. I don't, say we need to do a scan every year or anything like that. I do have some patients who have active cavanomas or who've got particularly complex cases where I may scan more frequently, but often I try to avoid scanning or at least space them out so we're not subjecting children to unnecessary anaesthetics. It's a question, though, that's still open. And again, it's one where I really try to speak to families and get a sense. Some families are reassured by scans. Some families find the scan themselves anxiety inducing. So ultimately, as a doctor, you have to think, is this actually going to benefit the child by having a scan? Is it going to give me information? Is it going to alter what I do? And if not, we probably shouldn't do one. So I'm going to sort of finish up. I think these are the sort of things I think are really important that I see as a surgeon. I mean, I think decisions need to be made collaboratively. It's not a question of you bringing your child to me and then saying, yes, you need an operation. Yes, you need gamma knife. Yes, it's a question of working together. And, just looking at the scan doesn't give you the answers. Quite often I'll get asked, can you look at the scan? Well, looking at a scan in isolation isn't very useful. You need to take a history. You often need to get to know these children over a few clinic visits to understand the impact the cabanoma is having on their life. And, it's easy to send off scans to big famous surgeons around the world. Maybe I'm not that famous, but sometimes I do get sent scans to look at from around the world. But actually, this is a predominantly clinical issue rather than a radiological one. And you need to get to know families and children before making decisions. Different teams may be involved. You may come to see me and I may say, actually, you need to see the epilepsy team. And that's a good thing. It's a good thing that you get opinions from different people. There can be a limit. Sometimes families will go and literally see 10, 20 different surgeons. I'm not sure how helpful that is always, but I certainly think, like I said, particularly in the situation of epilepsy, getting an epilepsy opinion is important. The family is the most important team, because ultimately you're the ones who live with your decisions and live with the child on a daily basis. So you always have to be comfortable with the decision that you're making. There is always going to be uncertainty. There is uncertainty with not treating. There's uncertainty with treating. I think sometimes families think once a decision is made for an operation, but actually there's uncertainty around the surgery itself, whether it will be successful, whether there'll be complications, and you can have problems even after successful surgery. So you have to be ready to bear the responsibilities of those choices. As I mentioned earlier, there's rarely urgency. You have time to make up your mind with cabanoma. It's not a condition, like say an aneurysm, where we're often speaking to families in an intensive care environment saying, I'm afraid we're having to take your child to surgery now, whether there is no choice. This is not like that you almost always have time to think about things, to go away. And I encourage that. I often, on the first visit, will show families the scans. I'll take a detailed history. We'll talk about what the options are. And I'll say, well, go away, think about things. I'll see you again in a few weeks or even a few months. Message me if you've got questions. I think that's a healthy way to do it. If you're not sure, ask someone else. I think second opinions are fine. I really don't mind at all if families say to me, well, actually, we've heard what you've got to say, but we'd like to hear what another surgeon has to say. In fact, I think it's quite healthy. And I think it's important, to get second opinions from the right people. And one of the things I'm very happy to do is to recommend colleagues from around the UK or even internationally who can give opinions. And I think it's also important to always be open, so if you've seen someone else and they've told me else, tell me. I don't mind. I won't be upset. In fact, I find it quite interesting and often then will spur more debate. And I think this is the really important last conclusion that I want to tell you is that I do look after lots and lots of children with cabanoma, and most of them do really well. Yeah, it can be very anxiety inducing for families to be told there's something on a brain scan. It may cause problems, but actually, the number of children I've seen who have been left permanently disabled or is very low. It's very low. And most children, regardless of the presentation, whether it's a bleeding with epilepsy or an incidental finding, live very happy, successful lives and kind of can forget about their cabanoma for most of the time. So, I want to leave on a positive note. And I think, again, just reporting what I see day to day in my clinic is, yes, often people are coming to their yearly checkup or their MRI scan, but other than that, they're just getting on with things. So it's a condition that I think, if managed properly, children will do well. Okay, I'm going to stop speaking and offer questions.
Thank you very much, Greg. That was fantastic. I think it was a really important point to make about the family and giving people confidence to ask for a second opinion. And I think your approach to that is an important one. And also, we will have some people here who may have got a recent diagnosis for their child, and to hear those hopeful points, because when you first get that diagnosis, you're uncertain, aren't you, how it's going to progress. So I think that was an important point to emphasise.
Someone's at my door. It's a bit embarrassing. Just give me 1 second.
Don't worry at all. I think we're all used to that with Zoom these days. So everyone, whilst Greg is just answering his door, just to say, if you could put all your questions in the chat, we've got a good 20 minutes to answer questions. It's a real opportunity to put those all in the chat. And Greg, this is the other point I was going to say as well. I think looking at these slides, I was just, really struck by the skill of the team at Gosh and the National Hospital. And, I think we're very lucky to have centres of excellence like Gosh and the National Hospital, and clinicians like yourself who are passionate about cabanoma. So thank you. So I'm now going to take the questions. We've got 7 in the Q&A and 1 in the chat at the moment. So I'll go one by one. So the first question is from Callum, whose child has been a patient of yours. Hello, Greg. Nice to see you again following a second opinion you gave us a few months back. Just out of curiosity, what is the minimum age for gamma knife?
Yeah, so that's good. That's a very good question. The youngest, not for cabanoma, but for a different condition, the youngest child I've treated, I think, is 5. And I think generally most centres would not treat below that age. I think that's for a combination of reasons. One, obviously, it is a radiation treatment. There is a Sheffield, who I think there's a question about Sheffield. Sheffield's the original gamma knife centre in the UK. They did quite a nice study looking at sort of all gamma knife patients and showed that despite radiation, there wasn't an increased risk of cancer, because obviously that's a worry with radiation. So they showed that there wasn't with gamma knife, it doesn't cause cancer. But still, I worry about irradiating very tiny children because of the safety aspect. Also, there are sort of practical aspects in terms of the way the treatment's done with the frame and everything that makes it more difficult in very tiny children. And I guess the other thing is there's not a lot of experience internationally in treating very small children. So generally, I would say a sort of rule of thumb is around 5, but there may be other children, there may be situations that arise in future where we do treat younger if there's no other option.
Thank you. Very clear answer. So the next question comes from Ian. Can you explain the difference between cabanoma and hemangioblastoma?
Yeah, so I mean, cabanoma is not a tumor, at least not in the kind of what we call like a neoplastic way. So it's not like on that kind of cancerous spectrum. It's a purely vascular malformation. Hemangioma is a kind of vascular tumor, and it's actually very rare in children, very, very rare in children. But I have seen it when I was training, because I trained in adults, and it's associated with a condition called von Hippel-Lindau, and you can get it in your eye and your kidney. But to my understanding, there are no direct associations between the two conditions, and they're managed quite differently, I think.
Excellent. Thank you. So the next question comes from Sandra. If a patient has both cabanoma and meningioma, when monitoring from a surgical point of view on both cabanoma and meningioma, should their neurosurgeon be a vascular surgeon?
Not necessarily, I think. I mean, it's obviously one of the sort of good things about neurosurgery is over time you become more kind of specialized, but the core training is the same for everyone. So I think it would be, there are many neurosurgeons that would be able to manage both conditions, and I think ultimately it will be someone you trust and who's someone who has experience in managing intracranial conditions. And and as I said, I don't think all children with cabanoma need to be under a neurovascular surgeon necessarily. I think there will be specific complex cases where we have certain training and expertise that's helpful, but I don't think that's necessary. And as long as you're happy with your neurosurgeon and they're sensible and kind, I think that should be fine.
Excellent, thank you. So question from Marie. For familial cases where babies are tested, especially if CCM3 and asymptomatic, when would you normally think about scanning?
Yeah, I think that's a very good question, and I think very, very difficult to. It's a thorny question, and I think screening is generally, I think, is something that, as a doctor, I think I have a different view on than I did, as a layperson. So I think sort of for a general screening question, often I get asked for various reasons, should I have a brain scan? It may be because of a genetic condition, maybe because another family member has a condition, it may be cabanoma, maybe something else like AVM. For example, I had a child who had an AVM, who had quite a nasty bleed and had an identical twin brother. So the mum was understandably extremely worried about the identical twin brother. The problem with screening, what everyone wants from screening is reassurance. So everyone wants to have an MRI scan and it's normal and they can forget about it. Or they want to find something that is predictable and treatable. So, okay, actually, the other brother has the same thing and we can treat it. The problem with screening is sometimes it can convert a healthy person into a person with a disease. So obviously, if you have, if you've never had a brain scan, you don't have a diagnosis, and you're completely healthy and living a normal life, if the next day you went in for a brain scan for some reason and that picked up, for example, multiple cabanoma, suddenly you have a diagnosis. It's something you have to, and it does have a lot of impacts in terms of potentially travel insurance, life insurance, driving, and it makes a person who's previously without a diagnosis someone with a diagnosis. And again, I go back to that thing about the scans. Is that beneficial for that person to have that diagnosis? If yes, if it's something that we can treat and will make them better, then great. But often, for example, in multiple cabanomas that we wouldn't necessarily treat anyway. So I'm always a little. I think screening has a role, and I think it obviously in this specific question, which is about a child with a genetic diagnosis, that adds another layer of complexity. Ultimately, it's going to go down again to informed consent from the family about whether they want to do that or not. And part of our job as doctors is to explain the pros and cons of screening. That yes, if we screen in, that may be reassuring, or it may show something we can treat, or it may find something you may convert someone who's otherwise healthy into someone with a diagnosis. Or sometimes we find completely incidental things. And in fact, some of the cabanomas I find I get are because people have had scans screening for other conditions. So it's a very complicated question. And I guess the flip side of it is the other one, which is if one member of the family has a familial cabanoma, should the other families be tested for the gene? And that's another difficult question for the same reason, in that, is it always helpful to know that? And I think probably the best people to speak to there are not just neurosurgeons, but also would be the geneticists and the neurologists. And I often have those kind of discussions with a group of professionals there, because I think it is a really, really difficult question and one that I think shouldn't be rushed into. It's one where you definitely want to think about the pros and cons of screening.
And we had this raised in another session, and we talked about the value of genetic counselling, and your answer really echoes other answers about it. There'd be no right or wrong, and it's such a personal matter. And you talked earlier about the importance of the family, and what may be right for one family may be different to another. So thank you for giving that balanced answer. So the next question: is there any particular advice that you give children about exercise and hobbies? So, for example, would you avoid high impact hobbies? And a common question we often get asked is things like rugby. Should that be stopped when
So again, ultimately it's going to be the family's decision. That I personally don't restrict any activities, and I base that on two things. One is personal experience, that I just don't see patients who've had bleeds after head injury. In fact, I've had one boy who fell from a lap and hit the back of his head and then had a bleed from a cabanoma. So I've seen it. It has happened to me once. But other than that, I haven't seen it. And also, there is quite a good paper. There was a paper. It's not specifically about Cavernoma, but it's about intracranial vascular anomalies in children. So it includes Cavernoma and other types of things like AVMs. And it was in America. And what they did is they looked at all the kids and looked at what sports they did, whether they did things like no sport or whether they did things like very low impact things, or whether they were doing American football and mashing their heads together. And what they found is actually there wasn't any difference in bleeding rate in those groups. So the data we have suggests that it's probably safe to do those things. I mean, what I often see in clinic is you can tell by the way the parent asks the question is, whether they want the kid to do it or not. So some mothers, I think, probably my mum will be the same, are looking for an excuse to stop their boy playing rugby. Luckily, I hated rugby, so it wasn't such an issue. And some kids are desperate to do these things. And again, I'm not the one living with it day to day. I'm the one I can sit in a clinic and tell you what I think. But as a family, you're the ones who have to carry that load. So the short answer, scientifically, I don't think there is any evidence that doing high impact sports is particularly dangerous to children with Cavernoma. But the sort of long answer is it will always be ultimately what the family feel comfortable with. I think the risk of having a bleed following a head injury with a Cavernoma is very low.
I think really helpful to have knowledge of that paper you referenced there, and just say to people, we know throughout our sessions a few papers have been referenced, and we're going to be building a research paper library on our website in the coming year, so that people can easily access this, because it'll be quite handy if you're one of those moms who wants to go, no, you might want to click on it. If do want to, that could be a helpful reference point. So I've got 3 more questions in the Q&A, and just to say, if you would like to ask another question, please do add to the Q&A. The next question: how do children find transitioning from adult services to paediatric services, which I know can be a real worry for people, particularly around 16, 17?
Yeah, it is. I think it varies. I think, it depends often on the individual. Some children are clearly ready to be, because really, I think when people talk about transitioning, I think there's sort of 2 aspects to it. There's a kind of experience of it, because I think the experience in a children's hospital is different from the experience in an adult hospital in terms of the amount of support available, particularly on the nursing side. Often there are dedicated nurses. Like I've got junior vascular nurses who are very involved with the families. There's not always the same counterparts in the adult services. There sometimes are, but their role is slightly different. Often it's less sort of stored and supportive. It's more organizational. But I think probably the other thing is the responsibility when children, in terms of decision making, because in a children's hospital we always look to parents generally, and we say, the parents are coming, they're talking to me, the child is sat there on their switch or whatever, paying much attention. Once you go to the adult side, then it's the young person who is the focus of care. So I think what I try to do is to try and bring the child or young person into the discussions early, and make it the point that they are going to be making decisions themselves. And, there are kids who at 14, 15 can make their own decisions. So I think it's really important as for us, is to start introducing the concept of that responsibility line with the child and young person. And I think also it's about developing a pathway within your own unit. So I'm lucky because Great Ormond Street is physically right next to Queen Square. And as you mentioned Queen Square has a lot of experience with Cavernoma. So traditionally I referred my patients to Neil Kitchen. Neil is winding down a bit, as you may or may not know. So I'm increasingly sending him to Patrick Grover, who's kind of taken over a lot of his vascular practice. So, it's quite, families I think are reassured by the fact that I know these people personally, I trained with them, and we have that open line of communication. So, and I think it's really important to say, once you've transitioned, that doesn't mean we forget about you. We're still interested in you, still care about you. And if you wanted, sometimes families will want to, or young people will want to speak to me again, even after transition, and that's totally fine. That we can facilitate that. But I think it's a process. It's not like a one-off event. It begins, I usually start talking about it at sort of 13, 14 years of age. But it can come as a shock for some families.
And just a follow-up question, because we often get this on the helpline. It's not uncommon that we hear someone will be discharged from Pediatric Services and they kind of sit there waiting for the referral to adult services, and that doesn't happen. And clearly you've got a really good practice set up within GOSH and the National. If someone's at a different hospital and that doesn't happen, what would you advise in that situation?
It can be tricky because I refer directly myself, whereas it can be the practice some places they say, well, you need to go to your GP to get a referral, and that can, as most people know, the NHS, it can be very slow and very complicated. I mean, I think I think it's difficult for me obviously to advise on because I don't always know what the practice is around the country, but I guess again, it's about, you have to a little bit sometimes be the squeaky wheel a little bit in the NHS. If you don't advocate for yourself, then often you will get. So I'd pick up the phone and I'd email the relevant people, whether that's the department that's probably both where you're meant to be going from and where you go. So what's happening. And I think one of the problems, and we've seen this occasionally, even we've got a pretty good transition set up, but is where responsibility lies in that hiatus. So for example, if I see a young person with a cabanoma and say, okay, this is your last visit here, I'm going to refer you to Mr. Kitchen. Obviously, it takes a couple of months for that appointment to come through. What happens if there's a problem in that position? So I think it's really important, and I always make it very clear. So basically, the responsibility will remain with Great Ormond Street until you physically have your first appointment at the National. That's the way we do it. And so I think it's really important to sort of ask and say, well, what happens if something happens in that period? Because occasionally it can get confused. And one of the problems as well is that obviously often your local hospital isn't your specialist neurosciences centre. So for example, in Great Ormond Street and Queen Square, we don't have A&E department. So if there's an emergency for my patients, they will present to North Middlesex Hospital or Hillingdon Hospital, something like that. And then that may also, because different local hospitals may have different policies. For example, for a 16-year-old, they may get sent to the children's ward, they may get sent to the adults ward. So it can get confusing. And I think that's why it's important to try and have a name of someone. You can say, I Mr. James's patient, or Mr. Kitchen's patient, or Mr. Murphy's patient, or whatever it is, because that will then hopefully let you get to the right place. So I always advise people to keep hold of their letters and records, because I think that they're really powerful. If you can show the team, look, this is a letter from my surgeon, then they'll know who to contact. So keep good records, and because the NHS, we do our best, but record keeping between trusts is often quite difficult.
Pest to power.
Yeah, and keeping records.
Yeah. So we have 3 more questions, which I think will take us nicely to the end of our session. So 2 from Alice, who a shout out to Alice because she climbed Snowdon recently for Cavernoma Alliance UK. And
well done. It's not called that anymore, isn't it? It's got a new name, but it's got a Welsh name. But I won't try. I won't try it. Yeah.
But so Alice asks, is the gamma knife process at Sheffield as child friendly as GOSH?
I think so. I mean, the Sheffield unit is the oldest gamma knife unit in the UK. I think it's the second oldest in Europe, and they're very, very experienced. I mean, a lot of what we do there, we base a lot of our treatment planning on their experience and their training. So I think it's an excellent unit. And I've not heard anything other than, I haven't personally seen their setup there, but I have spoken to them about it, and it seems to be very good, and the feedback I've had from families is good. So I think there are 2 centres that do children's gamma knife in the UK, us and Sheffield, and I think we both do a good job.
And then the next question, building on that, is if someone wanted a referral to Great Ormond Street for gamma knife, how would they go about seeking that?
Just get a referral to me, so either from your GP or from your specialist. If they send a referral to me, then we'll have a look at it. And sometimes we'll have patients, particularly with cabanoma, because as I said, it's the decision making around cabanoma gamma knife isn't always that straightforward. So sometimes we'll have patients that are originally seen in Sheffield, and we may give an opinion, or vice versa. And again, I actually know the guys in Sheffield, they're colleagues and friends, and I respect them very much. So sometimes families will want to get an opinion from both centres, and I think that's entirely reasonable, particularly because it is a somewhat controversial area.
Excellent. And our last question, is it possible to have a cabanoma that bleeds and then disappears?
Yeah, it's a short answer. I mean, we do see that, and sometimes it may, doesn't happen very often, but you will sometimes see cavernoma that bleed and then the scan doesn't show anything. I mean, obviously, one of the problems with scans is there is a resolution of scans. So like I was saying about the recurrences, I've had patients where I've done a post-op scan and the radiologist said cavernoma is completely gone. And then a few years down the line, you get a tiny little recurrence there because the MRI obviously shows, there's a limit to how small it can see. So whether it's disappeared or whether it's just so tiny that the MRI can't pick it up is difficult. And obviously, once you've had a bleed or cavernoma, the brain underneath it will always look a little bit different because it's been kind of scarred. So, but I think yes is the short answer. They're odd little things, as you've been hearing today, and I think sometimes they can essentially kind of involute. And if so, great. But like I said, I think we have to understand the limits of our technology, and saying a scan doesn't show anything isn't always the same as there genuinely not being anything there. So ultimately, like I said, the clinical surveillance is really important. So if you if you develop symptoms or something out of the ordinary happens, then report it. But yeah,